كل الأماكن منصورة أو خارجها. مجهود مشكور لاسم الأشعة. I have to be a bit more formal, so I'm going to speak in English if you allow me to. And this is a very distinguished occasion from the Radiology Department, which is a very active division in Urology and Nephrology Center. Dr. Mohammed Bulghar is a dear friend. He's a very enthusiastic radiologist, a very dedicated person, and a man with no conflict of interest according to him. So he's doing a very good job with the Radiology Department. Actually, and the Radiology Department since beginning, since inception, as of 1983, it has been a very active part of UNC. We are privileged to have them as urologists in this place, and they are also privileged to be in UNC because I think it is noteworthy that the infrastructure of the department as well as the machinery is progressing in a very astounding way. Even in the darkest days of COVID-19, we have been able, with their help and the help of the engineering department in the hospital, to install 128 slice CT machine. And it is only recently, last week, UNC has purchased another CT machine. This is the third one. So it's a hospital with 3 CT machines. The last and the latest is a Siemens machine that has been installed in Minyat Samanud branch, and we are expecting that we are going to inaugurate this service in Minyat Samanud next week, inshallah. So it's a very rapidly progressive department and active, enthusiastic people working in the outpatient in a very zealous and hyperactive way, doing a lot of good work regarding clinical service, which is the main target of this hospital. The clinical service directed to the Egyptian patient. This is the message and the task of the hospital, as well as research. So radiologists from Urology and Nephrology Center are marvelous people doing good job, having very good infrastructure, very efficient collaboration with academic centers in Egypt and abroad. I'm happy to be with them, and I'm very grateful to the generous invitation of Dr. Bulghar. And the topic of this session, I assume, is prostate cancer. And the first talk is supposedly presented by Dr. Ahmed Shal, who is, for unavoidable commitment, is not here, but his presentation is already available online. So we start with the presentation of Dr. Ahmed Shal, titled Triaging Patients into Prostate Biopsy. Okay. Start the presentation if you would.
السلام عليكم ورحمة الله وبركاته. صباح الخير. الجمع الغفير، يعني للأسف أنا كان المفروض أكون متواجد معاكم، لكن للأسف نتيجة urgent commitment أنا ما قدرتش أحضر، واستأذنت الدكتور أبو الغار إن النهاردة المحاضرة بتاعتي تبقى بري ريكوردد فيديو. الخاسر الأكبر من عدم الحضور هو أنا، لأن طبعا في treasure of information will be presented today من جمع من الأساتذة المميزين وأساتذتنا واللي بنتعلم منهم، دكتور طارق، دكتور أبو الغار، دكتور هيثم، الإخوة الزملاء من قسم الأشعة في المركز. وللأسف احنا يمكن بنشتغل في جزر منعزلة نوعا ما، فالميتنج such meetings بتبقى هي الفرصة الجيدة جدا إن احنا نتقابل ونتعلم من بعض. النهارده I'm going to present the urologist perspectives as regard the new approach for triaging pathway for prostate cancer diagnosis. And we have the well-known trial, PROMISE trial. I'm trying to summarize the data, and I'm going to present the urologist point of view as regard the insights of this trial. So what is the current diagnostic pathway for prostate cancer? So what we are using today and for years was digital rectal examination, PSA, and prostate biopsy. So, do all prostate cancer need treatment? This is the first step in the dilemma. The autopsy studies showed that 50% of men in the age from 40 to 49 years of age would have prostate cancer. 21% of men more than 50 would have prostate cancer, and 67% of men in the age of 80 years would have a prostate cancer. And so in the autopsy studies. So the unsettled issue is the potential benefits, how to weigh between the potential benefits and potential harms of diagnosing prostate cancer. And the problem or the caveats of the current diagnostic pathway is that it is a blind procedure. So the trust biopsy is applying to the location of prostate cancer. And from this perspective, many men without clinically important cancer undergoing unnecessary biopsy with overdiagnosis of clinically unimportant disease and underdiagnosis of clinically important prostate cancer. So, what do we need? We need to detect high-risk prostate cancer and systemically overlooks low-risk disease. In other words, we need to sort our priorities. We need to have triage. And what's triage? Triage is sorting priorities. And an emergency would make the triage procedure, or triage nurse would bring the worst cases to be the first, the high-risk prostate cancer to be diagnosed and get the priority in our workup. So here comes the multiparametric MRI. Why? Because it provides information about the prostate tissue anatomy, prostate tissue characterization such as cellularity and vascularity, and prostate volume as well. And there is some evidence that multiparametric MRI tends to detect high risk disease, and it can as well overlooks low risk disease, which makes it as an attractive tool or potential triage test. So I'm not going to go on the details of the MRI, but in short, the multiparametric MRI entails T2 weighted image, diffusion weighted image, and dynamic contrast enhanced image. And standard MRI, as we know, the T1, T2 weighted image MRI. So this is an example of multiparametric MRI showing a prostate cancer. And in the first image, this is a T2 weighted image, diffusion weighted image in second, and lastly, the dynamic contrast enhanced image of MRI. And the well-known, the famous PIRAD scoring system with different versions. This is a PIRAD version 2 with PIRAD 1 and 2 with low probability of having significant prostate cancer, PIRAD 2 with intermediate probability of having prostate cancer and significant cancer occurrence is equivocal, and PIRAD 4 and 5 with high and very high probabilities of having clinically significant prostate cancer. So the currently available tools for diagnosis of prostate cancer are either multiparametric MRI or template mapping prostate biopsy or the regular trust biopsy. When you talk about the prostate biopsy, the template prostate mapping biopsy, it's done using a template transperineal approach guided by the transrectal ultrasound and entails biopsy core from every single point of the prostate. The regular transrectal guided biopsy is a standard procedure, entails 10 to 12 course biopsy. So the template prostate mapping biopsy is able to accurately characterize disease states in men at risk of having prostate cancer by sampling the entire prostate. The standard biopsy entails taking 10 to 12 course prostate biopsy. So here came the known PROMISE trial. And why PROMISE trial? Because it changes our perspective and our point of view for the algorithm of diagnosis of prostate cancer. The title of this trial is Diagnostic Accuracy of Multiparametric MRI and Trust Biopsy in Prostate Cancer, a paired validating confirmatory study. The hypothesis tested in this study is that multiparametric MRI could be used as a triage test to decide which men with an elevated PSA might safely avoid immediate biopsy. So the aim of the work is to test the diagnostic accuracy of multiparametric MRI and trust biopsy against a reference test, which is a template prostate mapping biopsy. So this is study, a prospective, non-randomized trial. It's a multi-center study done in the United Kingdom. It carries a level of evidence of 1P, which is the highest available level of evidence for such workup. The study population chosen for this trial were men with PSA up to 15 nanogram per ml and digital rectal examination of T2 or less, meaning organ-confined disease, and no previous prostate biopsy. So the workup of this study entailed multiparametric MRI for all subjects, followed by combined biopsy procedure. Combined meaning template prostate mapping biopsy and standard transrectal ultrasound guided biopsy. Template prostate mapping biopsy core biopsies were taken every 5 millimeter of the prostate, and transrectal standard biopsy where 10 to 12 core biopsies were taken as per international standards. Herein I would like to emphasize that the international standards for taking prostate biopsy is 10 to 12 core biopsy. أنا بفكر نفسي وبفكر زمايلي إن دايما تراست بايوبسي الستاندرد هي من 10 ل 12 كورس، فنحاول دايما to stick to it. طيب نكمل. In the method section, the clinically significant prostate cancer in this trial was defined as prostate cancer diagnosed during the standard test, the reference test, the gold standard test, which is a template prostate mapping biopsy that incorporated Gleason score 4 plus 3 equals 7 or more, or a maximum cancer core length involvement of 6 millimeter or more in any of the cores. بنفكر نفسنا برضو ان الكور بتاع البروستات biopsy it should be at least 10 to 11 millimeters. This is a good core biopsy, and if it's involved with 6 millimeter or more in prostate cancer in each core, it means it's clinically significant prostate cancer. The outcome measures includes proportion of men who could safely avoid biopsy, proportion of men who would correctly identified by multiparametric MRI to have a clinically significant prostate cancer, and head-to-head comparison of the accuracy of trans-guided biopsies, the standard trans biopsy, and multiparametric MRI for detection of prostate or clinically significant prostate cancer. So the template prostate biopsy was chosen as a reference test because it samples the entire prostate, is highly accurate with an estimated 95% sensitivity for clinically significant prostate cancer due to its 5 millimeter sampling frame. So out of 740 patients registered in this trial, 576 men with all tests completed according to the protocol. 4 men didn't attend the final study visit. So here, the flow chart for our cases would be 576 index test, multiparametric MRI was done, and it suggests occurrence of prostate cancer in 418 patients to have clinically significant prostate cancer. In other words, PIRATE 3 or more. So the 576 patients had multiparametric MRI done for them, and 418 patients had PIRATE 3 or more scores suggesting clinically significant prostate cancer. And 158 patients with PIRATE 1 or 2 with PIRATE reporting of 1 and 2, meaning no cancer or clinically insignificant prostate cancer. So keep going through the flow chart of this study. Out of the 418 patients with PIRATE score of 3 or more, or as per multiparametric MRI, words of clinically significant prostate cancer, it means that the multiparametric MRI here suggests the occurrence of cancer in the 418 patients. Out of these 418 patients, only 213 had per template biopsy prostate cancer. It means 51%. This is a positive predictive value for the multiparametric MRI. When we look to the details of these cases, most of them were PIRATE 5. So the highest predictive value would go for the PIRATE 5 score as per multiparametric MRI. Looking to the negative cases, so 205 cases out of the 418 cases suggested to have high risk prostate cancer, were free of cancer or having low risk, finding that Pirate 3 represents the majority of these cases. Going to the other finding of multiparametric MRI, which is reported as Pirate 1 or 2 cases. 158 patients were reported as per multiparametric MRI having no cancer or no clinically significant cancer, representing 89.2% of the whole cohort who had suggestion. So the diagnostic accuracy for detection of clinically significant prostate cancer as per primary definition between multiparametric MRI and template prostate mapping biopsy was shown to be sensitivity of 93% and positive predictive value of 51% and specificity of 41% and negative predictive value of 89%. And we are looking mainly for sensitivity and negative predictive value for such a test. Why? Because it would be working at a proper triaging test. So the negative predictive value, it means that I can avoid having biopsy in how many of patients for diagnosing the clinically significant prostate cancer. So again, the other experimental test, which is standard transrectal ultrasound guided biopsy, is done for all patients and it diagnoses a clinically significant prostate cancer in 124 patients. And when compared to template prostate mapping biopsy, 111 of them were clinically significant and 13 had no cancer or clinically insignificant prostate cancer. So, diagnostic accuracy for detection of clinically significant prostate cancer, comparison between the TRAS biopsy, standard one, and template prostate mapping biopsy, it shows a sensitivity of 48%, so it's low sensitivity, positive predictive value of 90%, specificity of 96%, and negative predictive value of 74%. In this table, we're going to show the comparative statistical analysis as regards the main points of comparison, which is the sensitivity and negative predictive value. The first column here shows the multiparametric MRI, and here with the primary definition having Gleason score 4+3 and core length of more than 6 millimeter, suggestive of clinically relevant prostate cancer. The sensitivity here is 93% compared to 48%, which is statistically significant, and negative predictive value of 89% compared to 74%, which is again statistically significant. Changing the definition of clinically significant prostate cancer to a wider scope, including patients with Gleason score 3+4 = 7, and as we know that 4+3 is more aggressive cancer than cancer 3+4 Gleason scoring, with a less core length going down to 4 millimeter. Here again, sensitivity is 87% compared to 60%, again statistically significant. Negative predictive value is 72%, again is 65%, which again is clinically significant, statistically significant. Going to the less intense definition of significant prostate cancer with involvement of any Gleason score without consideration of the length of involvement in each score, more sensitivity for multiparametric MRI, more negative predictive value for multiparametric MRI. So the conclusion of this workup or this study is that TRAS biopsy performs poorly is a diagnostic test for clinically significant prostate cancer, and multiparametric MRI used as a triage test before first prostate biopsy could identify a quarter of men who might safely avoid unnecessary biopsy and might improve the detection of clinically significant prostate cancer. So let's go to practical point of view, our comments, our insight in such trial. So number one, the cost and time effectiveness. I'm going to expose every single patient to multiparametric MRI based on suspicion of having prostate cancer. Many would advocate further insight and further individualization for each patient. بمعنى اخر مش كل عيان انا هقول له اعمل مالتي بارامتريك ام ار اي قبل ما نعرضك لبروستات بايوبسي. بمعنى في عندنا variables which might dictate the need for multiparametric MRI and need for prostate biopsy زي family history، زي ال refinements of PSA بنشتغل عليها كتير من سنين ومعروفة، زي PSA density، ال free to total ratio، زي ال degree of obstruction. بمعنى آخر العيان ده جاي for intervention، خلاص العيان ده obstructed، البروستات بتاعته محتاجة ان احنا نعمل لها حاجة ولا لا، او هو جاي في regular visit و controlled with simple treatment so I can keep tracking the PSA and look after him. دي variables محتاجين نبص عليها قبل ما decide ان احنا نعمل such costly multiparametric MRI for every single patient. طيب بالنسبة للPROMISE trial في certain limitations we have to discuss. First that they were excluding large size prostate. Why? They excluded large size prostate that may result in a decrease of the proportion of true negative within the PROMISE trial. هم عملوا لها exclusion because the prostate over 100 ml had to be excluded due to the template grid size and bony pubic arch interference. يبقى هم ما يقدروش ياخدوا التمبلت mapping prostate biopsy for large size prostate، وعشان كده الكاتيجوري دي من العيانين were excluded. وده طبعا ممكن تعمل some sort of selection bias and we have to consider in our analysis of data. تاني حاجة ان البروميس trial represents a selected group of patients. هم عملوا exclusion للعيانين يعني اللي هم T2 اكتر من T2 او اللي البي اس اي بتاعهم اكتر من 15، وبرضه ده بيتسميه selection bias. فعشان كده we have to keep in consideration while we are extrapolating the data of PROMISE trial to our routine work. Direct limitations: the sequence of template prostate mapping biopsy followed by truss biopsy might have contributed to poor accuracy of the standard test. ليه؟ لأن أنت ما تاخد frame of 5 mm for having almost 30 cores biopsy or 34 or 35 cores prostate biopsy would end up by swelling, distortion, and tissue disruption in the prostate, which might affect the second biopsy, which is done by the standard transrectal ultrasound guided biopsy, 10 to 12 cores. The fourth, the blinding. في الستادي دي ما كانش فيه targeting of MRI suspicious lesions، وعشان احنا عاملين هنا نوع من انواع البلايندنج، وده مش موجود في الريال براكتس. انا النهارده لو عملت مالتي بارامتريك ام ار اي وقالت لي ان انا عندي في بايرات 5 suspicious area in the right zone of the prostate near the base, I'm trying to target it while I'm doing the transrectal ultrasound standard biopsy, and that you cannot accurately assess the clinical utility of multiparametric targeted biopsy approach in such setting. يبقى ده جزء مهم وما تعملوش assessment في البروميس ترايل. الخامس limitation في الترايل دي ان هم كان دايما اللي بيعمل reading للام ار اي two expert readers, so we need a further workup to require to measure the inter-observer variability of the expert and non-expert reporters of multi-parametric MRI. So what do I need as a urologist? I need to have the size of the prostate, how large is the prostate, is there a significant prostate cancer, where is prostate cancer, I need to know exactly the location for proper targeting during the biopsy, and I need to know the staging. So the multiparametric MRI would give me a suggested local staging, looking for the lymph nodes, looking for the capsular violation, for the neurovascular bundles. All of this data I need. So we need to have proper template reporting of multiparametric MRI. I need to raise this point. Again, we need a template to have a proper reporting of multi-parametric MRI of the prostate in particular. It's not MRI of the pelvis that we are reporting the shape of the bladder, the thickness of the bladder wall, the other soft tissue organs. I need to focus on the prostate and to give me the information about the size of the prostate, the probability of having prostate cancer, in other words, PIRAD reporting, 1, 2, 3, 4, 5. Where is the prostate cancer? And if we are having a high probability, PIRAD 4 or 5, I need to know an idea about the staging of the probable prostate cancer. So who needs multiparametric MRI? Men suspect to have a prostate cancer prior to biopsy, because the negative MRI may obviate the need of biopsy in 20 to 30% of patients, and we need it as well during monitoring, during active surveillance. The current protocol for active surveillance of patients with low-risk prostate cancer entails rebiopsy, and the rebiopsy is frequently a morbid procedure many patients would like to avoid. So in subset of patients who are having the low-risk prostate cancer and maintained on an active surveillance protocol, the well or properly done multiparametric MRI giving me an idea about the progression of lesions, changing in its characters, would be a very interesting tool to replace the routine biopsy procedure. This is what I have to say today, and I have to thank everyone, and sorry again for not being able to attend this session. Thank you very much.
Dear Professor Dr. Mohammed Abulghar, with his impressive lecture, which is about how to read multiparametric MRI in the area.
Screen